Hello and welcome to the NonProfit World TV show. I'm your host, Donna Hagiga, and today we are thrilled to welcome to the show our friends from the MavenProject.org, and we have with us today Lisa Schmerling, the Executive Director, Andy Laub, the Director of Programs, and Lisa Levine, the Chief Medical Officer. Thank you and welcome to our show.
Thank you for having us. Thank you.
Well, I was really excited to learn a little bit about the Maven Project, and it sounds like you're really helping to fill a gap in terms of there's community health centers, around the country that are really under-resourced in terms of physicians, and it sounds like the Maven Project is really helping to fill that gap in an innovative way. And Lisa, I was hoping you could tell us a little bit more about that.
Sure. Well, so the Maven Project, which stands for Medical Alumni Volunteer Expert Network, came out of the founder, Dr. Lori Green, who's a practicing OBGYN in California. And she had two things going on. She was a practicing physician, and in California saw that there was a huge need. There were still nationwide 29 million people uninsured, and so over 36% of doctors don't take Medicaid patients, so there's a huge need, and these patients are usually seen by safety net clinics. And the other thing that was going on was she was the president of the Harvard Medical School Alumni Association, and there she saw that there was a group of physicians, many of them semi-retired or newly retired, who were really thinking of ways of becoming meaningfully engaged, and they wanted to continue to provide medical care, but not in the same way. And so she thought about the two, and she socialized this idea of, well, what can we do to combine them? What if we built a national core of volunteer doctors and connected them using telehealth to safety net clinics and other organizations that could use them. And she talked to folks not only from Harvard, but also from UCSF, from Stanford, from UCLA, and later Tufts was also involved. And basically the idea was we could really leverage all of the medical physicians out there who are semi-retired, newly retired, or have an interest in volunteering even though they're involved in other things like working in a pharmaceutical company or on a parent track. And so from that, the Harvard Medical School Center for Primary Care funded a business plan, and the Maven Project was born.
Wonderful.
And what we've been doing is we recruit volunteer physicians. We then match them with communities or clinics that could use them. We facilitate their being able to provide direct consultations or curbside consults or education or mentoring using video conferencing. And then we've been able to really address some of the normal barriers to volunteers, physicians in the United States. So we were able to get medical malpractice that covered the volunteers, and the video conferencing really lets us be able to cross geographical barriers where you have clinics that are in sort of remote areas, rural areas. So it's sort of like Match.com meets the Peace Corps for volunteer docs.
That's a great way to analogize it. I love that. Tell me a little bit about that curbside. What does that mean? Is that not exactly virtual, or is it a different kind of, instead of video conferencing? So
the difference, so direct consultation in the services that our volunteers perform are, you always have a physician volunteer who's in one part, and then they video conference into the clinic where the patient and a medical provider, typically a nurse practitioner or a PA, could be a physician. The difference with, and there they're talking about a specific patient with the specific patient's information disclosed. A curbside consult in the parlance that we work with is really, it's advice from our volunteer doc being given to a medical provider about a patient in a de-identified way. It's advisory, the patient is not involved.
It's a little bit more like almost like it's one-to-one, but it would almost be like one of these things you see in a chat room where somebody's like, I have this issue, and then, but this is really medical professional to medical professional speaking without disclosing, you know, who the patient is, but talking about specifics.
Right, so for, you know, in a normal practice, a physician might walk down the hallway and ask their friend, you know, what would you do with this kind of patient, and this allows them to do that.
Okay. Andy, I understand that really the sort of key to this whole project working really well is the telehealth piece of it. And I understand that you had some background in that before coming here. What attracted you to this role, and what have you been able to bring to this? I understand that you're not just in charge of telehealth, but that's a big piece of it.
Yeah. The technology was very cool when they described it to me, but really what drives me is the mission, the idea of these volunteers giving up of their own time and helping the underserved is really the passion that drove me to come into this position.
Wonderful. And tell me a little bit about the telehealth. Is there any sort of concerns with like HIPAA rules and that sort of thing? Does that come into play? Is that something that you had to factor in when
we certainly had to think that through, and we now use a tool that's called Zoom, which is HIPAA compliant.
Okay.
So we definitely, it's on our radar screen to make sure that we remain HIPAA compliant.
Yes, and is that a tool that was developed for you, or is it a tool that you were able to find that fits the purpose?
We found it off the shelf and used that, and the reason we've used that is because that we find that the volunteers view that as being the easiest to use. And very convenient. Again, our volunteers love of giving their time, but doing so at their own convenience. So they're able to remain at home largely. Some do direct patient care, but most prefer to integrate this into their lifestyle, which Zoom allows us to do.
Sure. Lisa, I understand that you have very recently joined the Maven project, but I understand that you come from a background of being right within a clinic, or you've been working at safety net clinics before. Tell me what that experience is going to allow you to help with in terms of building the Maven project to even further allow volunteers to engage with these underserved communities.
Sure. My recent background was working with the dual eligible population in Massachusetts, the Medicare and Medicaid population, both under 65 and over 65, and working with a complex organization that was both a health plan and a healthcare delivery system. And what I recognized with this vulnerable population is truly how difficult it is to receive some of the necessary services and care that are needed for a population at risk. And this organization did a very good job of it. What I recognize is that that isn't prevalent everywhere, and that the access to, in particular, specialists and expertise with specialists is quite cumbersome on both the patient and the system in which they're living and functioning, whether it's within a community health center or not. So the burden of scheduling an appointment, scheduling transportation, and whether it's supports to either care for those at home that one is caring for, or to help safely accompany the patient to a specialist appointment, getting to the appointment, paying for the appointment, are all real burdens to getting some of the consultative expertise that we are able to provide to this population at risk. So when I heard about the Maven project, learned more about it, and recognized that the mission and vision of this organization is to take a highly skilled group of physicians who are altruistically donating and providing expertise care at a very, very at no cost to this vulnerable population. It just, a light bulb went off for me.
That's wonderful. It seems like the real, the biggest innovation in this delivery model is that availability of the specialist, because you might be able to find, I'm guessing, maybe some physicians, young physicians coming out of grad school, medical school, excuse me, maybe that you could get to do work in some of these community clinics, but they're usually primary care physicians. And what you bring to the table is, first of all, getting specialists to volunteer their time, but these are specialists who have worked for careers, so they've seen all kinds of things. How do you engage them? I understand that one of the original strategy was working through the Harvard Alumni Group, for instance. What are some of the other ways that you're engaging volunteers, or you're looking for ways to engage these volunteers?
So we use a number of different methods. The alumni associations, we still reach out to alumni associations. We've found that working with professional associations, to the extent that they can put a story or a blurb in their quarterly newsletters or on their websites, that's really brought and driven more volunteers to us. Social media has brought some, although the demographic of our volunteers may not always be on Facebook or Twitter. Oftentimes they have children who then say, hey, Dad or Mom, look at this. This is something you might find interesting.
Yeah, instead of telling me to get Jimmy a summer job, maybe you could start volunteering.
Yes, exactly. And one of the key things we're finding with volunteers, since the practice of medicine is so integral to who they are, that when they stop doing a full-time job, they feel almost invisible. And so being able to reach out and help and do something, but also have time to visit the grandchildren and to still travel. We have one volunteer who has taken calls from his house in Lexington, from his Cape house, and from his vacation in Tuscany and in Florida.
Nice.
And he just schedules it, and he's licensed in the state where the patient is seen, but he's able to do this from wherever.
And I would think that, I know from speaking to a lot of physician friends that more and more, the practice of medicine has become much more administrative. And so it sounds like this is like an ideal solution for those physicians, because they get to do what they love best, which is, treating the patient in a clinical setting, but not having to do any of that paperwork because the staff at the community center is taking care of that. So really they can just sort of really beam in for this consultation, talk about, what they see as the issue and, prescribe some sort of treatment or whatever needs to be done.
Focus on the care delivery and not the administrative burden. Right?
Yes.
Exactly. And I would just add to that the value proposition to these physicians who are volunteering their time is sort of multifactorial. And some of it is staying connected to a field which they've spent their entire lives dedicated to. And to your point, medicine has become incredibly subspecialized. So people are very narrow and specific in their areas of focus, but also have seen a lot of volume over time. So things that are very complex because they're super specialized to the primary care doc may be very quick, via telemedicine as a diagnostic meeting or appointment, and then an evaluation, sort of next steps. In addition, for many of the physicians, this is a way to stay connected with your clinical community. Which is, this is a part of it's part of your DNA.
Right.
It's part of what makes you you, and sort of hanging up that white coat if you're on the retired end or doing something different in your career and not seeing patients or any spectrum in the middle. There's still that need and desire to truly help and give back and to be able to leverage your expertise in a way that will benefit those that are underserved is just tremendous.
Yeah, that is wonderful.
And in addition, many of these folks, if not all of them, have time.
Right, exactly.
And that's and they can there's nothing more valuable in contributing time in addition to filling a gap for a huge need in this in the country.
I understand that in addition to these one-on-one consultations, there are some lunch and learns that happen. Tell me a little bit about that for whoever wants to jump in on that.
Sure. Do you want to, Andy?
Yeah, go ahead.
Okay. So a lunch and learn, what we've tried to do is, in addition to wanting to see patients, there's a number of volunteers that really like to mentor and to provide sort of education and teaching. And so this is an opportunity for them to share that, but in a very tailored way for a clinic setting. So they normally would speak for about 20 minutes on a particular topic. The audience is typically nurse practitioners or PAs. So, and then they have a Q&A, and it can be as small as a sort of fireside chat where it's just a few people, or it could be a room full of people. But the idea is to be able to really address practical advice and also to bring it to the health center where the during their lunch hour or during a regularly scheduled meeting, so that they don't have to travel and go out elsewhere. That one of the things with the health centers that we've found is a common mantra is that it's really hard to recruit and retain medical staff for a lot of the safety net clinics. And so as a result, they have a lot of people who are new. And so they come and they're bright and they're smart, but being able to sort of learn more about and take a deeper dive is really helpful. In addition, I think for the primary care professional at the health center, more and more the reimbursement is capitated, and so the more capacity that can be brought in-house to allow a nurse practitioner, for example, to diagnose and treat acne or eczema or other things like that that are sort of low-hanging fruit that would otherwise be farmed out is really helpful to the patient and to the health center.
Andy, is the Lunch and Learn, I know it's usually live, is that also taped for, there's the mention of staff sometimes keeps rolling in.
Yep. That you're anticipating where we'd like to go. Eventually we would like to tape those. Currently we haven't done that, but that is on our plan of scaling and how do we grow from our 3 original pilot sites, California and Massachusetts, to more broad-based. We're actually moving into Florida.
How do you pick those sites?
Those sites, we have a needs assessment program that we work closely with the clinic. We work with the executive staff of those clinics to make sure that they're going to support this. We have technology assessment that we do to make sure that they have all the infrastructure needed and a good solid team to help us do that.
And how do these community centers, how would they find out about Maven projects so that they could apply to become, considered for one of these test sites in the future?
Yeah, in numerous ways. Quite often it's word of mouth, but we also have our website, which people find out about either through professional associations or through participants, the clinicians themselves.
I would also add that, as we finished our first proof of concept pilots and have now been focusing on scaling, taking the regional sort of approach of looking for clusters of health centers, we've been approached by a number of associations, or we're also sort of talking to some ACOs, so accountable care organizations that have aggregated members that are involved. So often they're a mechanism for spreading the word that we're available.
I want to go back to something that you had mentioned. You had mentioned professional associations of physicians. And just to be clear, so that's something like if the physician is a rheumatologist, it would be her professional National American Rheumatology Association or something like that. That's also a recruiting tool, is that correct?
Yes. For example, the American Psychiatric Association recently wrote a little blurb about us, and we've received about maybe close to 10 volunteers have come in as a result of that.
And we've learned from that we really need to target certain, we have special needs in Massachusetts, for instance, as an example, endocrinology, neurology, dermatology, psychiatry are specific needs both in California and Massachusetts.
Oh, so that's an interesting consideration as you look at future sites. What are the sort of community health needs that may be more unique to that area? And then you try to recruit for that.
Correct, as a primary. And then we have secondary needs where we fill those with other specialists as well.
Lisa, you might be able to answer this from your experience working, at some clinics like this, and I'm not sure if this is something that Maven Project has undertaken yet, because I know you're only at 3 sites, but how do you handle, I imagine a good proportion of your population, depending on where the site is, may not be English as their first language. So is there an interpreter on the ground at the community center that the physician will then use, or how does that work?
You can
answer that. So we actually have, we had 3 states, but we have over 7 programs going on right now. But the way that the translation has happened in some of the health centers, for example, in California, most of their staff are bilingual. A few of our volunteers are bilingual. And then, for example, in one of the Massachusetts programs, they've connected with an interpreter service. So the idea is that if you think of the way the video conferencing works, you have the medical provider at the clinic on there, and you have the patient in the room, you have our volunteer remotely, and then the interpreter service can call into that call. So they're added as by a conference call in.
Yes.
Right. They actually, it'd be nice if they could do the video. That's probably the holy grail there, but right now it's done by phone.
Okay.
Yeah, just to add, there are plenty of language interpreter lines that are used around the country. In addition, I've heard some inklings of some of the web-enabled technology adding in interpreter services right into that technology. Right now, it does require a third party, but appropriate question given the diversity of these populations.
Andy, in terms of measuring success for your programs, what kind of metrics and evaluation tools do you have in place right now, or would you like to put in place? What are you?
Another important question. We have metrics we're starting to develop to take it from our pilot phase into our rollout and scale. And we're working closely with our partners to come up with those around cost, quality, access, and satisfaction, those dimensions. Because we want to demonstrate to our funders and to those clinics how effective our physician volunteers are.
And in terms of satisfaction, would you be doing sort of a triple play there in terms of the patient, the center, as well as the physician volunteer, I'm guessing?
Ideally, yes, absolutely. All three of those dimensions are critical.
And also looking at timely access. So one of the problems in some of these clinics is that they're so far out and there aren't any specialists. You mentioned rheumatologists. The clinic that we worked with in Northern California, there was no rheumatologist for 2 hours. And so being able to capture the fact that it would take a year for someone to get an appointment versus being able to get someone in within 2 weeks to see a rheumatologist, that's another metric that's very important.
It's removing a barrier to good health is because of
and being able to demonstrate that
location.
we can do that is, I think, important too.
And have you found that it has been useful as well with these specialists that not only can they, remotely diagnose and hopefully help to treat, but also perhaps know of practicing physicians in that geographic area, so that if there is some sort of issue that they could connect them with somebody?
There's been a little bit of that. One of the key parts is that the health center is really responsible for the continuity of care. So if there's a complex patient that needs to be seen, they typically have physicians that they would refer to. Now, there are instances in some of these areas, as I mentioned, where there isn't. In that case, our volunteers have been pretty industrious about trying to help us connect, or to perhaps have, if a Maven volunteer was to review the case, maybe consider that sort of a pre-qualified consult that can go to an academic center or whatever. But mostly that's the health centers who take care of that stuff.
Sure.
But one of the other key pieces that I would also add to, I would say in traditional sort of medicine practiced elsewhere, what happens is a patient is lucky enough to have a primary care physician, gets referred to a specialist, sees the specialist needs to communicate in some way back to the primary care doctor, and then the primary care doctor has to take action with the patient. And there are all these points in time when people are communicating and following up. The way a lot of this model works is that our physicians that are volunteering, part of the responsibility is they have to, at time zero, after they're either seeing the patient, working with the patient, or communicating about the patient, loop back with the primary care doc right then and there.
Then. So you're compressing that.
You're compressing even the time there. So there's compressed time to the appointment, but then there's a compressed time to actually taking action and closing the loop, which a lot of healthcare right now have open loop processes that aren't closed, and then there are gaps in actions taken.
I think that's a really critical point. Seeing the patient in their medical home, where they're used to getting to the center, they can get there, and then having it all be brought there is really helpful.
And that's where they're comfortable as well, which is
Yes.
a key. I think a lot of times, there's apprehension, even if they could go somewhere an hour away. This is, strange place. They don't know the people. Maybe
Absolutely.
they're,
They might not be able to make it to their appointment, so
Exactly.
meeting them in the home increases utilization and capacity of our.
It's an interesting, I know in sort of maybe some other models right now, we see it in women's medicine. You'll see these sort of one-stop centers for breast health. So, for instance, where you have your radiologist there, you have your, so it's like one-stop shopping where they'll read your mammogram or whatever it is, or MRI right away, so you don't have to wait, and there can be, follow-up. So it's taking that same idea, but bringing that to community health by pairing volunteers and using the best technology, it sounds like. So.
In fact, the clinic that we work with in California, they have all the social determinants of health sort of addressed, or many of them. They have a food bank that provides fresh food. You can get your dental work done there. They have a pharmacy in addition to they're having the medical consultation. So it really allows someone who is very vulnerable to be able to get the help that they need there.
Yeah, it's really smart thinking because they realize like that's where the audience is. So when they're there, let's try to help them in all the ways that we see that there may be some deficiencies, whether it's food or dental or nutrition counseling or that sort of thing. So that's wonderful. Do some of these centers, and maybe you know this, Lisa, from your experience, do they also provide child care when the person is being seen by the physician, or that really depends?
I think that really depends.
Yes.
It completely depends. And some clinics, remember, are family medicine focused, so that takes, you know, from pediatrics to geriatrics. But when you think about how do we create a health system that enables someone to receive the services that they need, some of the barriers are the need to be at home or at work to provide for the family.
Right.
So if you can't provide the supports to enable them to get to the appointment, or if you can make it easy to get the care that you need, some of those barriers, you know, get diminished.
So this type of program is obviously very expensive to build this system, right? To build the telehealth system, to recruit the volunteers. That's a lot of marketing and getting the word out there. How is the business model? How is that structured so that you, as a nonprofit, have the funding you need to get this amazing idea off the ground and really even expand on it, because there's such a great need? So
that's a really great question, and it's something I think as a nonprofit you have to take very seriously. What's the sustainability model? So we have sort of a two-prong approach. On one hand, we rely on some philanthropy. We've raised about $3 million to date. In fact, we have a $250,000 challenge grant out there. We also, so in that regard, the philanthropy has come from individuals, from family foundations, and some corporate grants. And we're always looking for partners who want to come along on this journey with us as we build this. But we don't rely only on the philanthropy. As Andy mentioned, sort of as we're starting to scale, we're also looking at ways that we can capture, if we can show good metrics and show that patients have better outcomes and that there's more timely access, can we then bring in other stakeholders, managed care, state and federal governments, and share some of the cost savings there. So I think that's a really important part of how you scale and become sustainable.
And have you also thought about using your model as almost like a franchise globally? So if this works here, could you then use this and sort of literally teach what you know?
We've had some discussions.
Yes.
They're up in New Hampshire. We had some folks who were suggesting that we do that and maybe have a model that people can then sort of license the knowledge that we have acquired in doing that, and that's certainly a possibility as well. We've also had some suggestions to, if we could really have a huge national stable of people, then perhaps that's something that folks would be willing to pay for a small subscription service for, so that they know they can always have access to these specialists.
That's smart. And how often has that happened, that you have a situation where you have one of your 7 programs, let's say, and somebody needs a consult with a doctor that has, let's say, a really rare disease, I don't know, something that they don't see normally. And do they come to you and say, well, we don't have anybody in our network. Do you have anybody in the Maven network who can be, we can have a consult with?
We've had a few inquiries from, for example, from the Special Olympics folks. We had a couple of requests for one of our geneticists that was already credentialed, and we were able to connect him. There was a patient with some heart trouble, and although he himself couldn't provide the expertise they needed, he helped connect them to people that would. That made a difference in that person's life. So yeah.
Yes, that happens.
And as you scale, certainly, so historically I think about about specialty care is primary care refers to a specialist, and then the specialist refers back to primary care. And what often happens is a specialist can refer to another specialist, which is a more subspecialized specialist. So as a need evolves around, let's take cardiology that needs a more subspecialized cardiologist, I could see that evolving as well as sort of a natural course, depending on the needs of the populations.
And do you think that there may also be sort of a more even preventative model eventually as well? Right now it seems like the model is based on really helping a point where the community center doesn't have that expertise, and we're bringing in that expertise through these volunteers. But do you also see opportunities where the community center may not be able to fully help the population with preventative care, and some of your volunteers could come and do some of these lunch and learns and different things like that, not only for the maybe medical practitioner population there, but possibly even virtually through your amazing technology to even the actual population being served?
I think that, for example, we're talking with a clinic in Massachusetts where they wanted to have best practices on treating their diabetes patients, so preventative care. And so one of the things there, our volunteer is going to be doing retina screens. So that's a way of augmenting that particular clinic and providing a service. In that case, it's asynchronous, where in the sense that the clinic will see their patients and take a retina scan and then send that to our volunteer who will read that a couple times a week on his own time. And then once a week he'll talk to their optometrist at the health center. And so that perhaps is a good example of where they're providing the preventative care.
Sure, exactly. And it sounds like it's being very responsive to the particular need of that healthcare system and that, population.
But we do envision also, Donna, to, again, not necessarily just have the care delivered in the center, but perhaps reach out to the member's home.
Yes.
We would work in collaboration with the clinic.
Which would be amazing, because then you're removing that barrier of having to go to the clinic to get education or, get as much information as it's often, people are working 2 or 3 jobs or whatever. They have children, they can't get out, but maybe if they could watch something that is, that's amazing.
Exactly.
One of the things that the health centers have, a lot of the safety net clinics have between 25 and 35% no-show rates. And so the more that you could actually, and it's because of the things that Lisa mentioned, where people can't get there, or they have childcare, or they can't take off from work, or the weather's bad. And so to the extent that we can still have the clinic be involved in terms of the continuity of care, but then it would be somewhat invisible to our volunteer whether the patient was in their home with a medical associate. So you can use someone who is a little more junior, but then the primary care physician or nurse practitioner could be at the center, and then the volunteer could be at their home. And have that same conversation, or school-based as well, has been another discussion, particularly in psychiatry. It's been an area where we've gotten a lot of interest.
And as these health centers become more capitated to provide population health, we feel that that's an avenue for us to really assist and really to leverage our business model and take it to the next level.
So at some point down the road, you may even have a test site that may be a school in particular for maybe psychiatry at least, if not some other issues as well. I could see where that you could use that technology, just really pivot a little bit so that really eventually maybe all 3 players would not necessarily have to be in a clinic setting. The patient could be at home. The nurse practitioner doesn't necessarily have to be at the setting either, and neither does the physician, as long as everybody was able to communicate in real time.
I think that's a really interesting idea. I think they'd have to bring along the payers so that because I think there may be some issues where they want them to be on site, or there's also sort of the emergency. So, one of the things, we've been very fortunate, we have not had any emergencies where someone really, had to be rushed to a hospital or anything like that. But part of that, the safety net in there is that you have a clinic person with the patient. So although even if you had someone go to their home, they would have the ability to get someone really quickly too. So.
Just any type of backup support system, on-call system, paramedic system that could also in an emergency
Sure.
situation support. I just wanted to go back to one point that
Yes.
you stated around sort of augmenting primary care or preventative care. And even with this specialty care, I think we do really view it as preventative care in the sense that our physicians who are volunteering their time are able to intervene with their expertise at a much earlier point in time than these patients would have had access to these specialists in the past, if at all, so that they are able to intervene earlier, manage things at a much earlier stage of their natural course of evolution, and both optimize outcomes for patients, decrease burden to them, decrease costs to them and to the system.
Sure.
So it's really a win-win for everyone.
Yeah, because but for that, this Maven project's intervention or coming into the situation, it would be a lot longer before somebody would be able to see a specialist because, as you mentioned, there's geographic considerations, there's cost considerations, there's just waiting to see if a specialist. Often you can sometimes wait a year to get into a certain specialty.
Huge waits.
So this is a wonderful way to compress that whole period and then affect better outcomes because of it as well.
Yeah.
One question I did have is the medical malpractice piece. I think that, that was the first thing when I was reading about this and seeing that these were retired physicians, I was like, oh, but how do they cover their medical malpractice? Tell me a little bit about that. Does it cover just, the work they do with Maven Project? Yeah.
Yes, that's one of the top questions we get from our volunteers, and they're one of their biggest concerns. And so we do provide malpractice. They are added to our policy for their activities that they're providing, that they're volunteering for in the clinic. We also, there's an intake process, so we do primary source verification and criminal background checks, which sort of translates into making sure that they are really went to school where they said they were, that they're in good standing, that they don't have any ongoing sanctions. So we do screens anywhere from first starting with a check on Google to then actually working with an organization that does the whole primary source verification and making sure they are who they are and their licenses are valid and their education is valid, and then working with another organization that does a criminal background check. So we take that, and then we also do an interview. So if ever there was something that was to come up, we would then identify that with to our insurance company, and if it was something we were still comfortable going with. And if someone's practiced for 40 years, it's possible they could have been sued some point in their career, but we want to make sure that if they were, that it wasn't something that was problematic.
Well, and especially because I think a lot of times with specialists, their rate of being sued is higher just because of their specialty and that sort of thing. So to your point, it's not necessarily because there was a lawsuit doesn't necessarily mean that there was negligence involved.
No, and we would never work with a volunteer that had a history of negligence or any kind of criminal background. So.
How about in terms of most of these specialists have particular board certifications and so forth that they have to retake every so often. So how does that affect it? I imagine that might be a barrier to keeping a retiree after a certain point if they have to sit for their boards all over again.
So a number of those volunteers are grandfathered in, so they might be board eligible, but or they maybe have board certification. It hasn't been an issue so far, but it's certainly a good question, and they do have to take CMEs to continue to have their license.
I know we were chatting about how you first got into law because you liked the policy piece of it. Is that something, from a policy perspective that you might look for an exception down the road if that's a good way of keeping your volunteers involved, if they could sort of continue to be grandfathered in for some of these things?
I think so. I think one of the areas that kind of leads us to is there's still a bar in the national level for volunteers because you have to be, if you're going to have a direct patient consultation, you have to be licensed in that state. But if you look at systems like the VA system where you can be licensed in any state but provide care throughout the country, we're really hoping that things will move down that way and that we can be a player in there to really make that easier. And similarly then, if you're going to have a system where it would allow volunteers who are in good standing in one state to practice volunteer as a volunteer in other parts of the country, one of the really important components would be the quality and making sure that if you have someone who's in their 70s, that they continue to remain as sharp as a tack. And one of the reasons Lisa was brought in was to also focus on the quality piece.
And yeah, and I know that you're very new to the position, so not to put you on the spot, but what are some of the ideas that you have for making sure that that quality is maintained throughout?
That's a great question. That's certainly on my agenda to build, but some of it, the way I sort of measure quality in general is both process and outcomes. So there are going to be some process measures that I think we'll probably look at around how things are done, and then some outcome measures around how do things actually turn out. To be built, but one of the things we do want to ensure, to reiterate what Lisa said, is that we want to make sure that the physicians that we're partnering with are still at the top of their licensure, that are still practicing modern day medicine that's consistent with the medications that are out there, the therapies that are out there, and that we're servicing our patients in the best and most optimal way that we can.
And there may be some peer review that's involved. I mean, as we begin to aggregate more volunteers, is it possible if you have a whole posse of rheumatologists, can they then help to do some peer review and perhaps have some mechanisms of sort of keeping everyone abreast of what's going on. One of the things that we've just found anecdotally is that the volunteers want to remain engaged. They want to keep learning, and so they're really sort of in tune to that.
Well, I think that you bring up a great point, because not only peer review, but I think that they would enjoy so there's this movement towards having team care for a patient, maybe in a hospital setting and so forth. So you have maybe your oncologist, your surgeon, your radiologist, whoever, they all manage that case together. They have meetings and so forth. So you could have that same sort of thing where maybe you have monthly meetings of rheumatologists to go over some of the more difficult cases they're seeing, in terms of what they're doing at volunteering at Maven Project, and bounce ideas off each other. As you mentioned before, in a regular clinical setting, you might go down the hall and talk to your colleague about it. But in this situation, they could build a network amongst themselves as well. They may not know each other. Like Lisa, you could be a volunteer, and Andy could be a volunteer. You could both be rheumatologists. You may not have met before, but because of that Maven connection, Lisa may contact Andy and said, here's what I'm thinking about this. What are you thinking?
It's an excellent idea. And one of the things we found when we did our orientations at the beginning of our first pilots, we had couple of group orientations, and we had to extend the time in the room because we couldn't get people out. They really missed being able to have that kind of interchange and talk about their practices and what they were doing, and that was really important. And the same thing happened even in the volunteer appreciation dinners where we talked about some of our results from our pilot. People really liked that part of it. It's part of medicine, of being a physician, I think.
And what physicians love most is caring for patients and cases about patients. So we are like stripping everything else that has been burdensome or cumbersome to many providers or physicians today, and asking them to, with some documentation, because we do want to know, what are the next steps, and sort of a note, but otherwise, here's the patient, here's the background, here's the case, help, here's the next case, and that's just like music to a physician's ears.
Sure. And maybe eventually you'll have so many physicians that some of them can team up just on the console as well, and you could make everybody happy that way. They have a colleague that they're working with again, no administrative paperwork, and the patient's getting two opinions in one setting. So
well, also even on the Lunch and Learns, one of the things, we've had a couple instances where we have had a couple rheumatologists that have been on the phone together and have talked about how they would divide up speaking about a particular topic. So you can imagine that you could also have a group of specialists who could talk about what the core core competencies that they want to make sure that they communicate to the medical providers are in that particular specialty, and they could do that as together. They each bring a different perspective, and it gives them that camaraderie. So
wonderful.
They also really enjoy learning more about the community that they're serving and getting background about where these healthcare organizations reside, so that they can be more informed about how to advise.
So that's interesting, because then you could have maybe somebody from the community sort of doing a lunch and learn back to the physician provider so that they get excited and knowledgeable about the types of people they're treating as well, and some of the things that they're encountering.
That's really, I mean, one of the health centers that we're working with in California is an Indian Health Service, and there the cultural competency piece is really huge, and that is something that needs, that having that come back to the volunteers. You know, right now we do, there's a letter and there's some background materials they read, and there's an orientation, but that's a really, doing that for a large group would be wonderful.
Yeah. And I think it would help both sides for sure, but particularly your volunteers to understand not only the community, but also understand the community that they're helping as well. So that's wonderful. So where do we go from here? What's next for Maven Project? It sounds like it's been an amazing setting up of this whole project, and you're in 7 programs right now in 3 states, or about to be 3 states, it sounds like, with Florida. What's next?
Do you want to grab that since you're operational?
Yeah, okay, so I think what we need to do is scale the business model, and to do so, we really need to take our lessons learned from these pilots, work with new clinics, work with our new chief medical officer, and help determine the vision of how to take this to the next level. So we're right in the process now. We ask your audience for any volunteers to come forward in terms of the clinics. We are excited to learn and work with new clinics as well as volunteers.
And Andy, if there are clinics that are watching this show, how best would they get in touch to say we want to be a clinic that would be considered?
Thank you for asking. TheMavenProject.org, that's our website. So I think that would be the easiest way, or contact any of us directly.
And that, I imagine, would also be the best way for volunteer physicians or children of physicians who want to volunteer their mother or their father too.
Well, that's a good idea.
Yes.
Absolutely. I mean, I think the long-term vision is just like there's a movement among many high schoolers before they go to college to have a gap year and do a volunteer. We would like, when you go to medical school, particularly because so many people come out with illustrious careers, to think about not just that I'm retiring, but I'm going to first do my Maven opportunity. So it's the same way as, say, the Peace Corps.
Yes. Yeah, that's a wonderful thought, and hopefully that will get out in front of more and more physicians, especially word of mouth as well. You know, if somebody knows about it and has a rewarding experience, they'll tell other people as well. Particularly, I think a lot of times, you know, specialists get to know a lot of other specialists, certainly within their own discipline, but oftentimes, especially as you move more to these team models of treating patients, there'll be more of that interaction, and there may be more of that word of mouth recruitment. Here's what I'm doing for somebody who is retiring, and maybe they, you can even get some sort of a Maven information pack as a retirement gift for
We are actually trying to work. We're trying to work with different
Yes.
managed care organizations so that when their staff retire, that when they have an exit interview, that they could get a packet of here's an opportunity that you could take, and it only takes 4 hours a month for a 6-month commitment. So it's a little commitment for a big impact.
your the medical insurance, the provider. Is this the same kind of provider that provides medical insurance to private physicians and healthcare centers as well?
Yes, although the difference is, so normally if you're practicing, you would have a claims-made sort of insurance policy. We have an occurrence-based policy, and it covers the pilot so that there doesn't have to be a tail at the end, and it only covers sort of what's happening in the pilot.
I'm thinking, though, that insurer, because they have many other customers who are physicians, they know when those physicians are dropping their coverage because they're retiring.
So Donna, we're always looking for strategic advisors.
That's right.
You've got some great ideas here.
Yeah, so that could really be
idea.
a great way of
We're actually meeting with our insurance folks this week, so that would be great.
So
Just as an outreach to physicians, we're looking for both pediatric and adult subspecialists.
yes, I was going to ask you about the pediatric piece.
Both.
Thank you for asking.
great. So pediatric and adult, and also I'm guessing adolescent would be covered by that as well. How about geriatric? Is that kind of covered as well? Have you found much of a need for that as well, or gerontology?
There hasn't been a huge need in there. One area that we're hearing about in endocrine is really on the diabetes front, and also in transgender issues are becoming more in endocrine too. So there's a need for those. It's the volunteers that are most needed are dermatology and endocrine and psychiatry, cardiology. But we do welcome physicians from other areas as well. But those are the prime areas.
Well, I can understand why you have dermatologists in high demand, because I think when I had made an appointment for a dermatologist a few years back, it was literally, I think, a 1-year waiting list to get seen. So I totally understand why you would want to have some of them in the network as well, and what a rewarding experience for them as well.
That's really huge, actually. In Boston, you could wait a week to go get Botox, but it would take you a year to go have a potential melanoma looked at. You know, so.
Yes, yeah. And speaking of melanoma or things like that, in addition to the video conferencing, are you doing anything with just photography as well, or photos, people sending photos as well in imaging?
We are. In fact, we're teamed with the Lynn Community Health Center, and we're working with them on technology that it's asynchronously sent. So their provider takes a picture of the patient's condition, and then it gets sent through a very secure server to the volunteer, who does a read of that and then sends it back. So that whole idea of it being asynchronous is another way of still using sort of remote access, particularly in dermatology and in ophthalmology. So the retina scans are also another way to do that.
That brings up a good question for you, Andy. Is there any kind of a file that's created if there's like asynchronous training, treatment for somebody, where maybe somebody is going to send a picture and there's going to be video conferencing of treatment and so forth? Would Maven Project be keeping files of anybody, or is it really just very transactional?
At present, it's very transactional. The clinic maintains the files.
Got it, which is probably much easier from your standpoint.
Exactly.
Especially in these days of hacking and cybersecurity and so forth. So, how do you stay up to date on all these technological developments and so forth? Is that on you, or do you have somebody who's a little bit even more IT expert?
We have more IT experts. We have consultants that we work with that keep us apprised.
Great. And then in terms of your staff, how is it staffed right now?
So we have about 10 employees and several consultants that work on a regular basis with us. And you don't want to scale too large, but everyone works pretty hard. It is a startup, and everyone really gives us their heart and their soul.
And I noticed that on your website that you were looking for a volunteer coordinator person, and is that for the physicians?
Andy, cover this one. We were really looking for someone.
Yes, please. Thank you for asking. A physician engagement manager, a marketing type manager, to help us engage our volunteers, our most valuable asset. And we look forward to having all those applications flowing in, thanks to your plug.
Sure.
We're looking for someone who can recruit, retain, steward, and also analyze what we're doing.
Sure. Make sure it's working, make sure that the types of, let's say, marketing tools that you're using to recruit are working. If they're not, find new avenues.
Absolutely.
What the needs of the volunteers are.
Wonderful. Well, that's great. So is there anything else that you would like to share with our viewers in our last minute before we have to go off air? Just mavenproject.org.
Right.
We're looking for volunteers. We're looking for somebody to manage the marketing and retention of the volunteers and evaluation as well, I guess. And also more health centers. Is that correct?
Correct.
Right, and we do have that challenge grant, which we would welcome.
Yes.
Anyone who would
donations for the challenge grant. Wonderful.
Yes.
And is there a time frame for that challenge grant that our viewers should know about?
It's in the next month. It's
great. And you said that was a $250,000
yes.
challenge grant. So that would help the Maven Project to really scale and get even better at helping to meet this unserved need or underserved need in community centers across America. Great. Great. So, well, thank you, all three of you,
Thank
for
you.
coming on. Lisa,
Thank you.
Congratulations on
Thank
your
you.
new position at Maven Project.
Thank you very much.
Andy, to you for the Director of Programs, certainly with the new program in Florida, maybe you'll get to go down while the
I hope so.
yeah, while the weather's still just here. That's kind of a nice place to visit. And Lisa, we thank you so much for coming and sharing with us not only how far you've come and what Maven stands for, but really where you're going as well. I really appreciate it, and I know I'll be watching the progress on mavenproject.org, and I know that our viewers will as well. So thank you.
Thank you so
Thank you,
much for
Diane.
having us today.
You're
Appreciate it.
welcome.